The following episode is brought to you by the American Urological Association. This episode features content from the AUA2026 meeting in Washington, D.C. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. Support for this activity has been provided by independent educational grants from Blue Earth Diagnostics, Inc. and Lantheus Medical Imaging.
Okay, I think we will get started. Well, thank you for joining us. My name is Minhaj Siddiqui, and I will kick things off. I will be the moderator of sorts today. And so the name of this session, it's a new session. It's called a Focus On series, and we are focusing on biomarkers, MRI, and PSMA PET imaging for prostate cancer. Let me just actually, I'm already veering from the script here, so let me get on script. So welcome to Focus On Biomarkers, MRI, and PSMA PET imaging for prostate cancer, presented by the American Urologic Association. The AUA strives to offer outstanding educational courses and greatly appreciates your evaluations and general feedback. So we are able to continue and improve these programs. We have a spectacular group of faculty here. We have Dr. Simpa Salimi, Dr. Mac Roach, and Dr. Michael Carducci. I will actually introduce them more properly in just a few seconds. The course faculty, educational council, and COI review work groups disclosures are located on the AUA 2026 website. The American Urologic Association would also like to thank the following companies for providing independent educational grants in support of this educational activity. Specifically for this activity, it is Blue Earth Diagnostics and Lantheus Medical Imaging. So thank you to those two companies for supporting this endeavor. The interactive course utilizes an audience response system. So make sure to have your phone and device available to participate using the ARS system. Okay, that's going to be coming up in just a few minutes. Please scan the QR code. I'm going to throw it up on the screen in a few minutes. And you got the handout, so you can actually join now if you like, so that you're ready, by scanning the QR code. There will be a pre-test and a post-test. We really do desire that you do both, so please, if you can participate, we greatly appreciate it. Course evaluations will also be available through the AUA 2026 website or app. Evaluations are a very important part and are read carefully by the faculty members and are used for ongoing needs assessment and selecting course subjects and faculty for future meetings, including focus sessions for 2027. And please be sure to complete the evaluation. It will also be your means by which you get CME credit. So with that, today's topic, why is this today's topic timely? So as I'm sure everyone in this room is well aware, the utilization of all of the modalities that we're going to be talking about today, imaging, PSMA imaging, MRI imaging, and biomarkers has exploded over the last few years. The indications for use has greatly gone up. You can see here just on the last 5 years or so, we're going from like a low single-digit utilization to 30 to 40% utilization. And this is actually not even the last 2 or 3 years, where I'm sure we're crossing over 50% threshold on some of these modalities. Also, a lot of these modalities are in the guidelines now and have been for a few years. And so the use of MRI, the use of PSMA, the use of some tissue-based genomics and other biomarkers have all kind of crept into the NCCN, AUA, SUO, ASTRO, ASCO guideline documents. And so, this is something that everyone needs to be aware of who's taking care of prostate cancer patients. And we're really glad to be able to put together a phenomenal session, I believe. We have the agenda for today is that we will be presenting on this topic from 3 perspectives. Dr. Salimi will give us the urologist perspective, Dr. Roach will give us the radiation oncologist perspective, and Dr. Carducci will be giving us the medical oncology perspective. We'll end the session with some cases that allow us to have interactive conversation on real-world utilization of these modalities. These are the speakers. I myself am a local. I'm a faculty member at the University of Maryland, where I am professor in chief of urology. Dr. Simpa Salimi is a associate professor of urology at the University of Michigan and the associate director for the Rogel Cancer Center. Dr. Salimi has a number of accolades, including the 2024 AUA Gold Cystoscope Award winner. He's been on some guideline committees such as the AUA Prostate Cancer Early Detection Guideline Committee and the NCCN Guideline Committee. Next we have Dr. Roach. Mac Roach is a professor of radiation oncology at UCSF. He was the former chair of the department over there. He has also been a nationally present mind in this space for many years now. He was an advisor for the NCI, for the IMRT working group. He was on the ACS, American Cancer Society Task Force for Screening Guidelines. He's been on the National Cancer Institute National Cancer Advisory Board, which covers the whole range of cancers. And then lastly, we have, but not least, Dr. Carducci. Dr. Carducci is the Agon Professor in prostate cancer research and a vice chair of solid tumor oncology at the Johns Hopkins University. Dr. Carducci has also had highly influential roles within this world of prostate cancer research and clinical practice. He was the former chair of the GU Oncology Committee for ECOG Akron and also was the associate editor for GU Cancers for the Journal of Clinical Oncology, amongst a whole host of other many impressive things that he's done over his career. We have 5 educational goals that we wanted to emphasize today. We want to critically appraise recent developments in imaging biomarkers and molecular diagnostics and discuss how they complement MRI and PSMA PET in prostate cancer care. We hope that today we will also be able to leave you with an ability to determine the optimal clinical scenarios in which to use these modalities, to recognize potential pitfalls in the use and interpretation of these modalities, synthesize biomarkers, MRI, and PET imaging into developing personalized plans for patients in the whole spectrum of care and the whole spectrum of treatments that are offered. And lastly, to select appropriate patients with radio-recurrent and organ-confined prostate cancer for advanced imaging and retreatment decision-making. So without ado, we will welcome Dr. Salami up to this stage.
Thanks, Dr. Siddiqui, and thanks to the AUA, the organizers of the program, for inviting me to speak in this session. These are my disclosures, and the only one that has a relevance to the talk I'll be giving today is the fact that I serve in the AUA and the NCCN early detection guidelines for prostate cancer. What I hope to cover in the next 10 to 15 minutes is how biomarker testing can guide management decisions, whether to pursue a biopsy or to determine what treatment to offer a patient after a diagnosis of cancer is made. And along the way, we'll review relevant guidelines recommendations. A biomarker really is any molecule in body fluid, be it blood, urine, or semen, or tissue that can be a sign of a normal or abnormal process. And within that context, we can also say that imaging, MRI, PSMA PET imaging, biomarkers as well. The first part of this talk will focus on how we can implement biomarkers and imaging for making a diagnosis of prostate cancer. And then the second part will focus on risk stratification after a diagnosis of prostate cancer is made. When you look at the landscape, the continuum of prostate cancer, I would say that we have an embarrassment of riches, if you will, in terms of the different biomarkers that we have available, be it blood-based, urine-based, tissue-based, imaging at different stages of disease along the continuum of care. Focusing on the early detection space, we use PSA. I think PSA is still the best biomarker we have. Is the most widely used oncologic, biomarker for making a diagnosis of prostate cancer and certainly for monitoring patients afterwards. And what we need to do is just figure out how to use PSA, well. But in addition to that, we have secondary biomarkers that, and this list is certainly not exhaustive by any means. There's still many more that are either undergoing development or validation at this point. But these biomarkers generally range from maybe a single molecule or multiplex biomarkers that have been shown in multiple studies to improve our ability to detect high-grade prostate cancer, which is the cancer that we really care about. And hopefully you can see this a little bit, but this is an older review published about 4 years ago, and it's already old, trying to summarize the performance of these biomarkers. And the reason why this is important is because we have so many of them, and we have limited data on comparing biomarkers head to head. I think that's what we really need to figure out what works in any particular situation. But put that aside, what you will find is that in general, these biomarkers tend to perform very similarly. The area on the curve tend to range anywhere from 0.6 to 0.8 in detecting high-grade prostate cancer at the time of initial biopsy or repeat biopsy. And overall, they tend to reduce the need for biopsy by about 20 to 30%. And they also tend to minimize the detection of grade group 1 prostate cancer. And these are the cancers that we really don't want to find because other than causing anxiety for the patient or the physician, they're very unlikely to harm the patient. And when used appropriately at the threshold that has been set by the developers of the biomarkers, the companies, you notice that you rarely miss grade group 3 cancers or above. One limitation or challenge, though, is that some of these biomarkers have not been well validated in a diverse patient population. And the reason why that is important is because the biology of prostate cancer is very heterogeneous. It varies from patient to patient. It also varies from population to population. And I'm just giving you an example here of ERG, which is known to have a low expression in Black patients. And ERG is a component of tests like ExosDS and MPS. This doesn't mean that they don't perform well in that population. This is just highlighting the fact that we need to test these biomarkers in various patient populations to facilitate their integration. But how should these biomarkers, be used? Should they be used reflexively or ordered routinely in every patient? Well, the position of the AUA, the NCCN, and the EAU at this point is that they are to be considered, optional, only to be used when they will change management decision. Certainly, at this point, we don't have sufficient data to suggest that they could be used in this screening setting. So they should not be ordered reflexively. So when might you consider using a biomarker in the early detection space? Well, first, ask yourself, when am I getting the test? Is it going to provide information that will be actionable? Oftentimes, providers and patients, we want tests that will give us a yes or no answer, positive or negative. But unfortunately, these biomarkers just provide you with risk, a probability, risk of having disease. So you then have to decide what action you're going to take. And you have to have a plan with the patient that the patient actually agrees to before you order a test. For example, you might get a biomarker suggesting that a patient has a 10% risk of high-grade cancer, and that patient will be like, I'm fine, I'm going to forgo biopsy. And then you have the other patient who has a 5% risk of having high-grade prostate cancer, and they want to biopsy like yesterday. So it's important to have a conversation with your patient, know what the action plan will be before you actually order a test. And we mentioned that these tests tend to provide very similar information, so there will be no need to order multiple or a battery of biomarker tests. And certainly asking whether the biomarker has been validated in the patient population of interest before you order the test, I think, is key. MRI. One can give, a 1-hour talk on MRIs, but we're not going to do that today, other than say that MRI really has been revolutionary in terms of improving our ability to detect, high-grade prostate cancer. It can help us to direct our biopsies as opposed to shooting, needles randomly in the prostate. So by so doing, it can increase our sensitivity of finding high-grade prostate cancer. And in patients with negative MRI, you may also be able to avoid a systematic biopsy or even a biopsy completely, depending on the clinical situation. So in that sense, it increases our specificity or our ability to do fewer biopsies. There's certainly, multiple data that has, demonstrated this, including one shown here by Dr. Siddiqui himself. Again, highlighting the fact that MRI really improves our ability to detect, high-grade prostate cancer. So what is the position of the AUA in terms of using MRI? I think at this point we feel that MRI is considered, optional in the initial biopsy, setting. Certainly if it shows a lesion, you want to do a targeted biopsy of the lesion and still do a systematic biopsy. And if in the initial biopsy setting, the MRI is negative, we'll still recommend doing a systematic biopsy. And then in the repeat biopsy, you want to get an MRI if it's not already done. And if the MRI shows a lesion, you target that area. And you could consider to forgo a systematic biopsy in that setting since you already have a prior negative systematic biopsy. And if you're getting an MRI in the repeat biopsy setting and the MRI is negative, you could consider foregoing a biopsy if the risk of harboring high-grade disease is really low. For example, let's say PSA density is less than 0.1. You could forego systematic biopsy in that situation. And if you're doing a targeted biopsy, we recommend 2 or more biopsies from the target. So we'll move on to the second part of this talk, using biomarkers and MRI, PSMA PET scan for staging and risk stratification. Once a patient is diagnosed with prostate cancer, the first question we ask is it confined to the prostate? And if it is confined, then we ask, is treatment necessary? And that is because some patients may be candidates for active surveillance. Patients with grade group 1 are candidates for active surveillance. Patients with favorable intermediate risk disease, so grade group 2 disease, may be candidates for active surveillance. And we often wonder, what is the likelihood that the cancer will progress over time? There are essentially 3 mechanisms of grade progression. It could be due to unsampled or undersampled high-grade disease at the time of initial biopsy, and by verse, the majority of cases of progression are actually due to undersampling. So we need tools to be able to predict whether this is the case when a patient is newly diagnosed with prostate cancer. And this is just a list of a number of tools that we could use. PSA density, you could repeat the biopsy. And the question is, can biomarkers help us in this scenario? Can MRI help us as well in this scenario? In this context, biomarkers can generally be classified into 2 groups. Prognostic, biomarkers, they provide information as to how that patient will do, what the outcome will be, independent of the treatment selected. Biomarkers like, Polaris or Decipher, Oncotype, Atera, those are all prognostic biomarkers. And you also have predictive biomarkers that can tell you what patient will respond to a particular treatment or what patient would be resistant to a particular treatment. And good examples are listed here. Decipher, for example, can identify those who benefit from adding ADT in addition to radiation therapy. Atera can identify those who benefit from ADT in addition to radiation therapy as well. Both prognostic and predictive biomarkers can be used to personalize therapy. Again, there is tremendous amount of data out there showing that these biomarkers do a good job in risk stratifying patients into low versus high risk and somewhere in between intermediate risk. But can they be used in active surveillance? Well, there are multiple studies that have been done, and they showed mixed or inconclusive results in retrospective data. And the challenge is because of the heterogeneity of prostate cancer. So your biomarker test is only as good as your biopsy. In general, grade group 1 cancers tend to have low biomarker test scores, and high-grade cancers tend to have high-risk biomarker scores. So at this point, barring any prospective validation data, the guidelines at this point recommend not using this test routinely in active surveillance setting, only if they would change or the results would change how you manage a patient, situations where there might be patients with grade group 2 prostate cancers or high volume grade group 1 or grade group 1 cancers in the setting of abnormal DRE, for example. And this, recommendations are similar to those of the AUA. This is from 2022, and the updated version, the recommendation remains the same. They should not be used routinely, but used selectively. The recommendations by the EAU is also the same. Now, those are somatic, biomarkers or biomarkers performed on the tumor tissue itself. How about germline biomarkers? Patients with BRCA1, BRCA2 are at high risk of being diagnosed with prostate cancer. Does that preclude a patient with grade group 1 prostate cancer from undergoing active surveillance? Well, this data is a very, very small cohort of patients with germline alterations in BRCA1, BRCA2, and ATM, just 26 patients compared with patients who do not. Patients with germline alteration were more likely to undergo upgrading or progression over time. But I still, think that it does not preclude them from undergoing surveillance, but rather you may want to have them undergo intense surveillance regimen. And then lastly, of the biomarkers here, I'll mention Atera AI. This is a multimodal AI model combining age, PSA, glycine, and H&E image. And what it found was that if you were to classify patients into model positive versus negative, positive shown in red, patients who receive ADT, who are model positive, were less likely to develop metastasis. They were less likely to die from prostate cancer. However, patients who were classified as model negative, shown in blue, they did not benefit from ADT in addition to radiation. Again, this is what we actually need, tests that can predict response to specific treatment. And so in the NCCN guidelines, this was introduced in 2024 and remains there today as one of the predictive biomarkers. Should we use MRI in active surveillance? We do, but the challenge with MRI is that there's significant amount of variability in interpretation. It also has a number of performance issues that limits its implementation or as a substitute for biopsy. So in the active surveillance setting, at this point, we recommend not doing MRI any more often than every 2 years. You don't see significant changes if done more frequently. And at this point, the guidelines committee recommend that it should not replace, biopsy. A biopsy is still necessary, and MRI is simply to guide your decision, to guide how you perform, your biopsy. And then the last imaging test that we'll talk about is PSMA PET imaging. This is a systematic analysis of 27 publications, nearly 3,000 patients, showing that PSMA PET is actually a very good test, for staging for prostate cancer. It has an AUC of 0.84, but the sensitivity is not that great, 58%. It has a high specificity and negative predictive value, meaning that patients with negative PSMA PET scan result, the likelihood that they will have, metastasis is actually quite low. When you compare that with nomogram that we currently use as well to identify who should undergo node dissection versus not, it does pretty well. At 7% predicted risk of lymph node invasion, the negative predictive value of PSMA PET is 98%. It's more than 99% at 2% predicted probability of lymph node invasion. But we still need to figure out how to use this in determining who should get lymph node dissection versus no lymph node dissection. And this is a trial that is proposed by one of my colleagues that is currently undergoing evaluation to be done through SWOG to determine who should get lymph node dissection versus no node dissection. So in conclusion, I think biomarkers improve our ability to detect group 2 prostate cancer. They help in our ability to risk stratify patients into high versus low risk. The challenge is that genomic biomarkers or tissue-based biomarkers are limited by the heterogeneity of prostate cancer. We have to use them selectively, only if they will change management decision. And certainly MRI and PSMA PETs can facilitate our ability to risk stratify patients. And with that, I'll thank you for your attention.
Thank you. I think what we're going to do is run through the 3 talks, and then so if you have, we'll have a Q&A opportunity. So if you have any questions that you think of, let's wait for the 3 talks to go through, and then save your questions so that we can do a little bit of question and answer. So next will be Dr. Mac Roach, who will present the radiation oncologist perspective.
Well, thank you for inviting me. It's interesting to see Dr. Salami's perspective as a urologist in the initial workup and evaluation. And I use the MRI and the PET scan every day in the actual management of patients. So when I'm designing the radiation, I use a lot of stereotactic body radiotherapy focused on the prostate. We use MRI images fused with CT images, and we use the PSMA PET images to design targeted areas where we give extra doses of radiation to the pelvic lymph nodes. Now, I'm not really going to talk about the technical details of how we use that. I'm going to spend a little bit more time on the biomarker part of it, which he showed you one slide, which I'll just skip through. But I wanted to emphasize PSA a little bit more. I mean, everybody thinks all this other stuff is new and it's exciting and PSA is kind of boring. But actually, it's important to understand it took us a long time to understand PSA, and I think it's going to take us a long time to figure out what we want to do with all these biomarkers, and a lot of validation is going to be required. So in this 10 minutes, we're going to talk about some of the limitations of the biomarkers of genes, the first biomarker, which is really PSA, and some of the issues related to PSMA PET and MRI. So this is from some data, joint study, UCSF, UCLA. This kind of data was used to actually get FDA approval in our country for PSMA PET. And the problem is the sensitivity was only about 40%. So that's actually an excellent test, because before that, we had at least something that was about half of that in terms of being sensitive. So it's a much better, it's the best test that we have for evaluating the status of metastatic disease, particularly in pelvic lymph nodes. This is a nomogram that was developed by surgeons in Europe, and this nomogram is based on being able to predict which patients are likely to have lymph node involvement with a negative PET scan. And so what you can see, this is from the same paper using different algorithms, but these are patients that had a negative PET and they went to surgery, and 13% of the people had positive nodes. So from a radiation oncology standpoint, I still radiate the pelvis if it's a high-risk patient, even if the PET is negative. Now, I said I use MRI every day. It does have independent prognostic significance in terms of the risk of recurrence after surgery, but we use it because actually the first paper that compared MRI to CT I wrote in 1996, which showed that the prostate appeared to be larger on CT than MRI. So when you're doing stereotactic radiotherapy and you want to deliver very high dose to the prostate and you don't want to excessively radiate the rectum or the bladder or the penis, you really need to use the MRI. It's a more accurate way to target the prostate. The previous speaker defined biomarkers, so I'll skip. But just to give you an idea of, some of us have been working on this biomarker, in particular PSA. This is over 20 years ago. We wrote the first paper that showed that PSA actually predicted death from prostate cancer, PSA over 20. We showed that, but PSA is overrated. Many people think that if it's a high PSA, they have to have metastatic disease. Not true. We also have some data from our prospective studies that talk about the significance of PSA nadir as a prognostic factor, and it can be a surrogate for death from prostate cancer under certain circumstances based on data of RTOG9202. And then I'll share with you one paper that was just presented at ASCO GU by Dr. Kishan arguing for PSA as a biomarker in the post-op setting. So this is our first paper, joint data from UCSF and University of Michigan, that showed that PSA over 20 predicted death. But this is a study looking at patients who are high risk only because they have a PSA over 20 versus patients that are high risk because they have a high Gleason score. And what you can see is that if you have a patient that walks in the door and their only high risk feature, if they have a low Gleason score and low stage, but they have a PSA over 20, that PSA over 20 is not as important as the other parameters. This is a nomogram that was created by Dr. Katan, and the nomogram on the left is one that predicts biochemical failure, and the one on the right predicts metastatic disease. And what you can see is that most people think that metastatic disease is a good surrogate for death, and the things that predict death are T3 disease, high Gleason score, and the things that predict biochemical failure are PSA driven. So you have to understand that depending upon what the question you're trying to answer, PSA is and the reason, again, I'm talking about PSA is we haven't figured out what we want to do about all these other biomarkers, which are much more recent, and we need to validate them. And here's a study looking at patients with high-grade disease that have low PSAs. And this study suggests that if a patient has high-grade disease and they have a low PSA, their prognosis may be worse. So PSA, again, is somewhat overrated. Now, this is from the Poseidon study that Dr. Kishan in a multi-institutional setting put together. These are multiple studies looking at post-op patients. And the question they were trying to answer is, how much is hormone therapy really beneficial to these people? And if so, how long should they take the hormone therapy? And as you can probably see, I don't know if you can see, is the pointer working? The curve on the right says median PSA 0.5. So basically, in this analysis, Dr. Kishan suggested that there was not much of an impact of PSA, of an interaction between the PSA level and the benefits of hormone therapy. Now, and so when he talked about the limitations of his study, which are shown here, I don't know if you can read them, but he was saying that they were spread out over a period of time, that the only long-term hormone therapy that was used was bicalutamide, and that maybe GU006, which I'll talk about in a minute, might show that hormone therapy can be important. But I think the most important critique that I would make of this study is actually the fact that the follow-up is relatively short. So, and I'll come back to that in a few minutes. Whenever you're talking about biomarkers, you need more time. But you can see that these curves here are going out to about 10 years. And this curve is starting to separate maybe a little bit. And I think that the issue of follow-up is really critical when you evaluate some of these things. Now, this is another biomarker that we recently come to appreciate more than before, which is the cribriform pattern, cribriform positive versus cribriform negative. And this is from the PROTECT study. So with long-term follow-up, it turns out that we now have something that we've seen in pathology reports for many years, but only recently have come to understand how that would drive recommendations, and again, something that we need to validate with other data. So the biomarker in GU006, which is a study looking in the post-op setting, the assay that was evaluated is the so-called PAM50 assay. Now, this was pioneered initially in breast cancer and showed that there were different patterns that can be seen, luminal A, luminal B, and basal phenotype. And so the effort was to say, well, what if we apply a similar system in prostate cancer patients? So this was the first prospective phase 2 randomized trial attempting to validate a biomarker. And in this case, and again, this is courtesy of Dan Spratt, this is looking at radiation with placebo versus apalutamide, and it showed that in the patients that had the luminal B phenotype, there was a big impact, but in the non-luminal B, so that would be basal phenotype and luminal A phenotype, there appeared to be no advantage of using the hormone therapy. And this was also shown in the metastasis-free survival. So we now have this biomarker that's been validated prospectively in a trial. Now, the previous speaker also talked about the Artera assay. This is using artificial intelligence. So we have many thousands of tissue specimens. These things have been scanned in and digitized and used to, and then studied, and this slide was showed, but basically the bottom line is that those patients who are marker positive had a big benefit of using, this is 4 months of hormone therapy compared to none, versus those people who were marker negative. And then we also have, this is work, again, which needs more validation. This is looking at SNPs, single nucleotide polymorphism. So these are normal tissues that are used to predict toxicity. So what you see here is that there are patients that were receiving stereotactic body radiotherapy. So we're talking about 5 fractions, and patients that are getting conventional radiation. So you're talking about like 35 fractions or 40 fractions. And if you look at the freedom from grade 2 urinary toxicity, there was a unique signature that was associated with having toxicity because the treatment's given over 5 sessions, and this one having toxicity if it was given prolonged. Most people don't have this signature. So my typical patient, when I'm trying to decide how I'm going to treat them, if I'm only going to radiate the prostate, the first thing I do is I do this so-called ProsTox assay, and if the ProsTox is unfavorable for SBRT, then I have them run the assay with conventional fractionation to see whether or not the patient's likely to tolerate that. It's a very rare patient that doesn't tolerate either, in which case I tell them they should get a radical prostatectomy. Now, this is an example of a report from a patient Here you have the Artera assay that shows this patient is marker positive. So this would suggest that the patient would benefit from using hormone therapy. This is the Decipher score. You can see that the score is high, so this patient has unfavorable prognosis. But on the other hand, the PAM50 assay shows this patient is luminal A phenotype. So these are could be perceived as somewhat contradictory, and this is one of the challenges that we have with these assays. So this tells us that theoretically, the phenotype of this patient is not that responsive to hormone therapy because it's luminal A. But this multimodal AI assay is based on the Gleason score, the stage, the PSA, as well as features that are seen on the pathology slide. Now, some of this may be explained by heterogeneity. That is, certain parts of the prostate you may not always be comparing the same section that's being evaluated using Decipher and the piece that's being used to do the AI assay. Here's an example of a Prostox assay, high risk for SBRT. We call Prostox Ultra, and this is low risk for conventional fractionation. Marker negative, which says don't do hormone therapy. So what this says is this patient doesn't need hormone therapy, that he would likely do well even if he did not get hormone therapy. But this patient has luminal B phenotype, which says that his cancer is responsive to hormone therapy. And the question is, does he need it? Now, I alluded to the Poseidon study that Dr. Kishan presented, and this is from some surgical data, and there are several other studies that have the exact same conclusion, that when you look at the risk of death from prostate cancer, which is the black part of the curve, you can see that basically 80% of all the patients or more that are going to ultimately die of prostate cancer die between year 10 and year 20. So for your typical patient who walks in the door, localized prostate cancer, the typical time to death is going to occur between year 10 and year 20. So what we're looking at is when we're evaluating biomarkers and evaluating PSA, and our follow-up is only out to 10 years, we really don't have enough events to evaluate some of the biomarkers. So the good news is that we do have an opportunity with more studies and more tissue that we have. For example, we just completed recruitment to a 2,500 patient study. We have tissue from all these patients. We're doing biomarkers on all these patients. The median follow-up is 7.3 years, but in a few years we'll have long follow-up. We'll be able to look at all these biomarkers together and adjust for other factors, and that should allow us to validate the importance of the biomarkers. So Einstein said, not everything that counts can be counted, and not everything that can be counted counts. And I say you have to count what you can count and hope it counts. And thank you very much for your attention.
Thank you. All right, and I'll welcome Dr. Carduccio.
Thank you, Dr. Siddiqui and the AUA. The medical oncologist is often the last doctor anyway. So I'm going to give a broader overview of more about advanced disease or metastatic disease. So you have my disclosures. So I'm going to cover prostate cancer working group 4. So this is a new nomenclature, how we use our biomarkers when we're doing clinical trials, or how we sort of get things approved, but also how does that mean to our clinical practice? Where do we use novel imaging? And particularly, we've got targeted drugs, particularly the PARP inhibitors for advanced disease, and why that means germline and next generation sequencing is important for folks with advanced disease. So Prostate Cancer Working Group 4 just came out in the JCO earlier this month. It was presented at GU ASCO in the fall. And again, the last one was Prostate Cancer Working Group 3, published in 2013. 2016, so it's been 10 years. And so why do we need new guidelines? Clearly, there's multiple new agents approved, particularly androgen receptor pathway inhibitors, the PARP inhibitors, PSMA radioligand therapy, radium-223, and a lot of these have been now moved to the hormone responsive disease setting. We've got PSMA PET imaging with limited data as to sort of how to use it to follow disease. We've got the indications about staging and putting it into place, but how does it change over time? How does it respond to therapies? And so we don't have real clear guidance on how to do that. We've also sort of been talking in the field about sort of having softer language instead of using the word castration. It scares men even more than just what the whole disease is. And so looking at words that sort of are a bit softer, we've talked about in this process. We have a lot of biomarkers now that we have to incorporate, and for advanced disease, it's really a lot of the genotype and phenotypes and how they change over time. And many of the other biomarkers are a little bit early for us in terms of how we use. And then more recently, there's a little bit of disconnect that sort of we always see PSA declines, responses, but the disease may underneath be changing, particularly when we use novel imaging. So this really summarizes sort of the state's model moving from clinically localized disease to advanced metastatic disease. Again, the non-metastatic pattern after surgery or radiation therapy or old biochemical recurrence is sort of losing its luster because with novel imaging, PSMA PET imaging, you're finding disease that you know has to be there, and so now you no longer label them as non-metastatic. In the past, we always felt that they were metastatic, we just couldn't see it. And so the language here, instead of using hormone-resistant or hormone-sensitive, castration-resistant, we're looking at sort of recommending to the field that we change it to androgen pathway modulation sensitive, or APMS, and then androgen pathway modulation resistant for the old castration resistant. That sort of really it's how one's going to respond to sort of pathway, androgen pathway inhibition, which has been the core of therapy for advanced prostate cancer. So the state's model still moves, but we're less worried about if you had chemo before, you had PSMA before. It's really what have you had before, which is important in determining what you might do next. And so when we're looking at how folks respond to therapy, and particularly in clinical trials, we sort of put them into silos and we ask folks to describe them individually and then sort of put it together. Is the patient benefiting? So again, you've got PSA and serum biomarkers. We've described that in previous working groups. We still get bone scans. Again, that's sort of as earlier presented. Why do we do that? The PET scan's more sensitive. But most of our trials still wanting to say what disease is there, what disease is potentially threatening. I think PET scans tell us the disease is there, but it doesn't tell us how it's going to behave. Whereas more anatomic imaging says it's there, it's big enough that it could be threatening. And then you've got molecular imaging. So non-imaging response criteria, so these are looking at PSAs and sort of we're trying to figure out are there early markers. And right now we don't have anything that sort of documents success. But we do have a number coming in terms of circulating tumor cells, ctDNA, whether they change, you sort of put a more composite endpoint together that not only does PSA go down, but circulating tumor cells change. Those aren't readily used in practice. They are available to us, but how we use them is still early. Putting in patient-reported outcomes is very cumbersome for our clinics to sort of see how we report them and what other markers are changing that we've always had, alkaline phosphatase, LDH, and whether hemoglobin improves or albumin. So those all are put into context of benefit. So what we did in Prostate Cancer Working Group 3, we found out very early that we got rid of drugs fast because the bone scans or CAT scans changed, and we felt that was flare. So we asked folks that sort of, you get a scan about 8 to 12 weeks after their first therapy, and if it shows more disease, you keep them on study. That's just your new baseline. And therefore, out, you needed to have at least 2 new lesions to say it's new. Since prostate cancer can progress slowly, we don't want to change therapy unless there's clear progression on scans. Patients don't like it when you hear the word new in scans, and so trying to hold them through that. The prostate cancer working group changes that sort of after you've gotten that first scan, any new disease would count as progression. That's the change in prostate cancer working group 4. But the biggest changes and recommendations are how to use PSMA PET. Again, we don't look at recognizing getting PETs very early after you start treatment. Less than 8 weeks, we don't know what that means. After 8 weeks, you can really probably stand on what it is. We don't know whether volume changes, SUV parameters really mean anything. That's investigational. So we're not recommending that you determine a partial response or progressive disease based on SUVs or volume. We're looking at getting that data so that we can actually move to the next working group. And we ask that sort of if you're going to get a PET CT, to get it with contrast so that you can continue to use the RECIST component of measuring disease with the CAT scan. So the rule of 5 that we put out was sort of, again, with PET scans showing multiple lesions, many lesions in some cases for advanced disease, that if you start out with, you change and you have less than 5 lesions, 2 new lesions that are confirmed on a subsequent scan would count as progression. So we allow 5 new lesions, and if we follow that with the next scan, and if they're continuing to progress, that means progressive disease. But anytime if you see more than 6 lesions, that is progressive disease. So this is all sort of putting out there as a strategy to sort of how we should follow patients with PET scans. Clearly, any new disease or change in disease in visceral disease would always recommend that count as progressive disease. So how do we take that to the clinic? We're sort of looking at all these molecular imaging that we have, and clearly the PET scans show more metastatic disease sites than bone and CAT scans. So if you've been using conventional or anatomic imaging, you switch to PET, patients are freaked out because all of a sudden there's more disease. It's that we know about more disease and we don't know how that disease is going to behave. So far, we know that doctors do different things based on the PET scans, but we haven't really shown a lot of studies that what we do improves outcomes. We change therapies earlier. We don't give people therapies. We send them over to the radiation oncologists a lot earlier. They're doing a lot more radiation because we find things and we are all bought into the oligometastatic paradigm. If we can find it, let's chase it. So clearly these say that we do different changes, but we have to sort of do the long-term studies seeing if it changes out thing. So it still goes back to basic clinical practice. How's the patient doing? What are the scans doing? Do I need scans now to tell me that? And what's the PSA doing? For me in practice, if 2 out of 3 are going in the wrong direction, I change therapy. Part of this now is that we need to have molecular testing, and many of the recommendations is do it at least a couple times over the course of therapy to see if it changes as tumors can mutate, to see whether the targeted therapies can be available. Over the last 30 years, we've got a lot more agents that are out there. We've got all the second-generation anti-androgen modulators, immunotherapy, PARP inhibitors, 3 different chemotherapies, radiopharmaceuticals, and continued with supportive care. But we are needing molecular sequencing because we see about 20% of patients having these mutations. They're higher in folks with Gleason 5 or folks with ductal features. We also want to look at tumor mutational burden or MSI disease because there's indications for pembrolizumab for that patient population. We do see a wide variety of how practices work, sort of, hey, I want you to get this test, you get it, and then send them to a genetic counselor if you find that there is a germline, or you send them to the genetic counselor and let them do sort of the prep work for the patient so that they know that if they do find something significant, you may have to do cascade genetic testing for family members. But remember, folks are I try to sort out with my patients, do they want to have a mutation, not have a mutation? But you got to tell them that 80% of the time we're not going to find anything. So we're looking for something, and it's a pretty low return. Who needs germline testing? Anyone with metastatic prostate cancer, those with very high risk or high risk localized disease, folks with a family or personal history with BRCA1 or 2, Lynch syndrome, HOXB3 associated prostate cancer, those of Ashkenazi ancestry, and those with family histories of known germline variants. and those that when you do tumor sequencing, you find a mutation that could be a cancer predisposing gene, you should follow up with germline testing. So the PARP inhibitors are really sort of the classic. We have a molecular mutation, and we now have 2 U.S. approvals for just folks with homologous recombinant repair mutations and those with specifically BRCA1 or 2 mutations. So you've got PARP inhibitors for either of those indications. But since then, we've also sort of now combined them with androgen pathway modulators, and we've learned a lot about it, that even though you've got broad definitions for HRD mutations and many genes in those subsets, we've done folks a disservice saying that you're likely to benefit if you have one of these genes. In reality, there's a lot of data now that suggests those mutations that they're not going to benefit. These drugs certainly have toxicities, anemia, fatigue, nausea. So this is a study from the FDA who actually pulled together from all of these studies and showed that BRCA2 is the biggest star there, is going to be the highest benefit when you're using a PARP inhibitor. And then you got BRCA1 and CDK12. But if you look at this, the ATM and the CHEK2s, you got hazard ratios over 1, really suggesting that even though they fall into the category and you've got approval to give the drug, the likelihood of benefit is pretty low, and so you need to monitor those patients very frequently, whereas you're likely to see PSA declines and in clinical improvements with the other mutations on the slide. We've also been sort of behind the 8 ball. We've combined it with androgen pathway modulators and show that the 2 drugs together for these populations with mutations do benefit. There are some of these studies that suggest it's better for all comers, but there are not labels in that direction. And the other thing is, now that we're starting to use PARP inhibitors, if you know right away for androgen pathway modulation sensitive disease, I did it, I used the new terms, those patients can sort of be using this. So now the question is, do we want to do doublet therapy? And it's very consistent that if you haven't added in an APM and you know that they have a BRCA1 mutation, to use the doublet. We know that sort of earlier use may be beneficial, and there's been an approval now for the androgen pathway modulation sensitive disease if you know that they've got an HRD mutation, to give a PARP inhibitor. So we really recommend that at this point that we should obtain germline and NGS sequencing to guide therapy. It helps us particularly with those with BRCA1 and BRCA2. We've got lots of data about people presenting with early metastatic disease to sort of at least do doublet therapy and consider triplet therapy in those that are younger and high volume, and particularly de novo disease. And you see data coming out all the time now about adding, if you know their BRCA, to add niraparib. At ESMO this year, we had the PSMA addition suggesting adding in lutetium PSMA-617 with metastatic hormone-sensitive disease. And the FDA just reviewed the cabometyl data with an AKT inhibitor, those with PTEN loss at the time of hormone-sensitive disease. So we also allow about using second-line hormone therapy. It doesn't make sense. We've got to figure out when to use drugs like lutetium, PSMA, and we still have to remember that drugs that sort of seem a little bit more toxic, radium and chemotherapy, they have a real role in advanced prostate cancer as well. So that's where I'm going to stop, and happy to answer questions when we get to the panel session.
Okay, great. Well, we're going to open up for Q&A now. So if people have any questions that they want the panel to comment on or discuss, this is an opportunity to kind of come on up to the microphones and pose your questions for the group. So go ahead and make your way up. You know, well, actually, we have people coming up, so I'll let people go ahead and comment.
A question for Dr. Carducci. I don't know that there's evidence, but I'm wondering what your thoughts on, in principle, on combining PARP inhibitors in an all-comer population with lutetium.
It may be reasonable. I mean, again, there are certainly a lot of different labs and approaches trying to show that with, DNA breaks and using the PARP inhibitors that you may have it. Toxicity may be a little bit more excessive in that setting. So I do think we would have to be very careful, but it would be an approach that certainly could be evaluated. Mac?
I have no idea.
How do you guys manage the information overflow with all of these new biomarkers coming in, studies on like the use of like, the kind of sensitivity, specificity of the different things coming in, and then also as people are, radiologists are getting better and agents are getting better, like it's been, everyone's practice has been changing so quickly.
I would say it's probably closer to mismanage this milieu. I mean, the point I was trying to make talking about PSA is it took us all these years to figure out what to do, what its limitations were, and so forth. And now we've got these new biomarkers. And I actually, when I showed those cases where a patient had one biomarker that said one thing and another biomarker that said another thing, that's because I was able to order both tests. And part of the reason why I order both tests is that it actually gives me an opportunity to learn more about the test and the limitations of the test. So I'm not sure that I can take credit for managing this complex milieu of options that we have out there, but I am optimistic that we'll figure it out, but it's going to take some years to figure it out.
I think ideally what you would want is to see how different tests perform in the same situation and ask the question, what test is best in this particular situation, what test is best in another situation or patient population. But it's going to be difficult to get that kind of study done. Right. So at the end of the day, the patient and the physician, particularly the physician, will have to look at the data and say, okay, this is a test that I'm comfortable. I understand the data. And in our minds, we all do this exercise of, what is convenient, what value am I getting from it, what test will it be easy for me to ask, to get done, what test will it be easy for my patient. For example, if I need a urine test, it will be easier to do a test that does not require DRE than a test that requires DRE. So those are the things that go on in our mind, and then you figure out what test you're gonna order. But you're right. I think we have an embarrassment of riches when it comes to biomarkers, but the challenge also is how to use them.
I think it creates a lot more uncertainty as to sort of if a patient comes to see me and I'm going to refer them for salvage radiation, it makes it less certain as to me what the radiation oncologist is going to say to the patient so I can prep them. So you're trying to sort of say what, are they going to do short course, long course this month? So these tests come in, and I've had a couple, like Mac showed, these just discordant results that sort of, and the patient's coming in for me to solve it, and I'm like, I don't know. I think we're all going to figure out how to sort of interpret these tests together.
Yeah, please.
Very great presentation also with regard to the biomarkers and the DNA having 20% positives, 80% we cannot clarify now. My name is Ralf Wirtz from Stratifier from Germany. 20 years ago, I started with breast cancer. Then we did bladder. There's tomorrow a presentation on biomarkers, predictive biomarkers, how to select the patients. We did this also in prostate in the meantime. So there will come more biomarkers. I don't want to scare you. They are expression-based. And then you can take ADCs or then small molecules where you can also target the drugs even more effectively than with ADCs. So I think I want to give you some hope for the 80% which we cannot resolve at the moment with all this genomic testing, right? So, for example, HER2 and some others are coming.
Yeah, I think we're going to be able to individualize a lot of folks in terms of what they express on their tumor cells. And again, figuring out drugs like ADCs and other, immune gaugers that sort of can target those it's a pretty exciting time.
On this topic, and then we're going to get into cases. We have plenty of cases to fill the time, but so we'll probably just do a couple of them. But one more thing I'd love to hear everyone's comment on. What do you do when you have a clinical management plan that is fairly well indicated in a patient based on traditional metrics? So a urologist, a biopsy, and Gleason score and PSA indicate active surveillance, and you happen to order a biomarker, and it says, no, that's not the right thing. This person is high risk, not low risk, despite everything else that you thought you were going to do. Or there's so many variations of the same theme, right? Like these new markers are showing results discordant with what would have been a traditional plan of care for a patient. I'm sure everyone's kind of encountered this at this point. How do you navigate both your own thinking and taking a patient through that process?
Well, I think the data on the cribriform positive and negative stuff is really worrisome in terms of recommending active surveillance on a patient, because that data needs to be validated, but the way it looks is that those patients do very poorly long-term based on a prospective randomized trial, and actually they do much better with radiation and hormone therapy than they do with surgery. So you might, there is prognostic significance and predictive information that data tends to suggest. But what makes the question you just asked even more challenging is that, all of our earlier studies were based on patients staged by digital rectal exam. And I can tell you that residents don't like to do doctors don't like doing digital rectal exams anymore. And so how do we manage patients who walk in the door now that come to me with a biopsy and an MRI that says probable or possible T3 disease, and all of our studies are based on patients that had clinically T3 disease by rectal exam, which meant they get long-term hormone therapy. What do you do with these people? And I can tell you that in the UK, they tend to use MRIs to stage people, but at UCSF, we don't, or at least I don't. So it's even more complicated because we don't do the same things and we're not seeing the same kinds of patients.
Yeah, I think, for me, I used to go to our multidisciplinary clinic, and the medical oncologist didn't have a role. We could leave, but with, PET imaging, how everybody's now, what should we do? You see some shift away from surgery, more radiation, more aggressive therapy. So I think, if you're going to make a change because you ordered the test, I think folks lean in that direction, but it's still a conversation with the patient about sort of, here's what it would have been if we had not done this test, here's what we're going to do based on this test, and see where folks fall out.
Yeah, that's why I think it's critically important to think about how a test will alter your plan before you order the test. If I have a patient with grade group 1 prostate cancer, regardless of what a biomarker test, tell me, I'm going to do active surveillance. So if the patient wants the prostate out, I'll send to a second opinion. Maybe he'll find somebody else who will take the prostate out. So if a test is not going to change what I do, then I would order the test. But let's say a patient comes to me with grade group 1 prostate cancer with high risk to decipher. I'll say, okay, maybe we'll do a biopsy sooner than later. That's how I would proceed.
Yeah, having a purpose for your test still remains a fundamental concept. Okay, let's do maybe a case or two, and first case is a 66-year-old male who presents with an elevated PSA. This patient had a PSA of 1.6 in 2018, which crept up to 3.3 and then 6.7, so fairly rapid trajectory there. DRE is normal. Past medical history is pretty benign, other than just some skin. Patient undergoes an MRI. This is what the MRI findings show, and I will just direct people to this area here, right there. Let's just make it a little easier for everyone. And so going right over there. And so that demonstrates a 67 cc prostate with a Pirates 5 lesion in the left peripheral zone with base measuring 3 centimeters, possible seminal vesicle invasion. It's just kind of abutting, pushing into it. Lymph nodes looked okay. And so a biopsy is performed, which demonstrates 8 out of 13 cores that came back as 5+4 Gleason 9 cancer. So at this point, why don't I let doctors all three, if possible, but maybe Salami and Dr. Roach, you can give some thoughts on what your thoughts are on this patient up to this point and what you're thinking as next steps.
Yeah, so this patient has very high risk, prostate cancer, grade group 5 prostate cancer in multiple cores. Interestingly, PSA is only 6 and PSA density is 0.1. MRI, you said, shows no evidence of lymph node involvement, so I think I would proceed with further risk stratification with a PSMA PET scan is what I would get in this scenario to evaluate for metastasis.
Great. This is the PSMA scan, and it really was just focused on a prostate finding, which is going up against the seminal vesicle as well on this, but no nodal disease. Dr. Roach, do you have any thoughts on this?
Yeah, so this is a classic patient that I see every day. We treat him with hormones and radiation. He would probably, depending upon who he saw, he might get an additional drug like Abby or something else that would be added. They would do that in the UK based on their Stampede data. I tend not to do that. I would consider it in him because of his age. Usually if they're over 70, I wouldn't be so enthusiastic about adding other drugs. But this is a classic patient that we see. My recipe involves hormone therapy. I like to do a stereotactic body radiotherapy on the prostate first, followed by pelvic nodal radiation. Even though his nodes are not positive on PET, as I said before, the PET could miss nodal involvement. He's certainly high risk. The older data from Parton's table suggests that patients with seminal vesicle involvement have a 50% risk of lymph node involvement. We have data from a randomized trial that would suggest that we don't have long enough follow-up to answer the survival question, but we do have an improvement in biochemical failure with treatment of the lymph nodes prophylactically and long-term hormone therapy. And
from a surgical perspective, I would counsel the patient as well. I think the fact that there's no lymph node involvement on MRI or PSMA PET scan, I will still do an extended lymph node dissection at the time of surgery for this patient. And then I'll also counsel the patient that patients with very high-risk prostate cancer have 30-40% risk of biochemical recurrence within 5 years of treatment. So this is a patient who is going to need multimodal therapy, either at the very beginning with radiation plus hormone therapy or, surgery and then radiation therapy at some point.
So he was counseled on both options, and the patient ultimately opted for surgery. So he did undergo radical prostatectomy with extended bilateral pelvic lymph node dissection. Gleason 9 cancer again was seen. There was indeed seminal vesicle invasion. The margins were negative. There was extraprostatic extension, so it was a T3B tumor. There were some biomarkers sent. The Decipher score was sent on this, which was high risk, 0.98. There was some genomic testing shown, mutations in P53 and HRAS, stable for MSI and low for TMB. Dr. Carducci, do you think of anything at this point? It may be a little early for you to really do too much with this patient at this point. I'm going to show some PSAs in a second, and that'll help. But you probably interpret this more than any of us.
Yeah, I mean, again, it just looks like it's truly prostate cancer. The Decipher tells exactly what we knew clinically and by the Gleason. So I didn't get a whole lot of information from this. And, I'm with Mac about whether or not you would add an abiraterone or not. I tend not to if I don't see obvious nodes. If I see nodes, I add it in. And some of it's based on age, but this wouldn't push me one way or the other.
They didn't say how many nodes were taken. Yeah. How many nodes were taken?
It was extensive. I actually don't think I wrote it down, but I think it was like something on the order of 20. I mean, it was a thorough clean out. Post-surgery, 8 weeks, the PSA is 0.16. 12 weeks, it looked like it was going to 0.1, but then 24 weeks, we're at 0.17. I'll open this up to actually anyone who has some thoughts and comments at this point on what you think.
Yeah, so, the question is, do you, barring the PSA, do you offer adjuvant radiation to a patient with PT3B disease, or do you wait for PSA to rise and then you offer early salvage? But looking at that, I think that's where the biomarker testing you did may change my recommendation. As a patient with high Decipher score, PT3B disease, you may consider doing adjuvant as opposed to early salvage. Certainly with this PSA profile, I'm referring him to Dr. Roche for adjuvant treatment.
I mean, it's a little bit of semantics, whether it's salvage or adjuvant. The standard definition is greater than 0.2, so he hasn't crossed that threshold, but, it's kind of looking like a fish and smelling like a fish, so I think it's a fish, and I'd recommend that he got hormones and radiation, and we would treat his pelvic lymph nodes based on our randomized trial, RTOGO534. And there's actually some data suggesting that high Decipher score patients were the ones that benefited the most from pelvic radiation. So he would get hormones and radiation.
That's indeed what happened. Hormone therapy was started with Lupron, Abi, and prednisone, with a plan to do it for 1.5 years, and an EBRT to the prostate bed and the pelvic lymph nodes. And the patient has done well from that. Dr. Carducci, any thoughts on the ADT there, and especially with some of the extra information?
No, I think, again, this guy, because PSA is still detectable, even though it's not the 0.2, I would say it's salvage. And I think that's an appropriate regimen for that, and that's what we would do.
Great. Well, that's the end of that case, and actually I think we're going to just move over to the final questions. I'll give one last opportunity for questions if anyone in the audience. I see one coming up. Then we can load up the post. Yeah, thank you.
I have two patients that both recently had negative PET scans. One recently diagnosed with high-risk disease. The prostate didn't light up, nor there's any extra prostatic signal. Another patient recently came to me, had a radical 2016 with follow-up radiation, and he's had several PET scan PSAs, about 5 or 6. PET scans are negative, and I'm wondering if going back just to a bone scan and CAT scan instead of the PSMAs, and getting back to trying to find something that PET scan's not picking up.
So the first patient that you described was not treated. He just has a negative PET scan.
Yeah, it's the first time after the biopsy I saw him, he has a PET scan. Right.
So I recommend treating that patient because there's actually a paper published in JAMA looking at patients with, they have a nomogram, a salvage nomogram, sort of like, the Stevenson nomogram years ago that showed the relationship between success and the PSA level. This one takes into account the PSA level and the PSMA PET. The first author's name spelled ZAMB something, and it suggests that patients with negative PETs that get salvage radiation actually do better. So some urologists are like, no, let's just wait until the PET shows something and then we'll treat you. No, the patients
I'm in favor of treating. It's trying to explain to the patient that if the PET scan's starting to pick up the prostate cancer, why is high-risk disease not being picked up?
Because the PET scan is only 40% sensitive from the beginning. So if you miss half of the nodes that would be there, then in the salvage setting, in the post-op setting, it means that the volume of disease is relatively low. It's below the resolution, and in that setting, a negative PSMA PET is a favorable prognostic factor. The second patient is more complicated because that patient's already been treated, and in that patient, you start to worry about things like, is it a false negative? Because sometimes there's a recurrence at the anastomosis. Sometimes it's hard to pick up a lesion which abuts the PET agent being excreted in the bladder. There are other factors, but those patients are a problem because they've already been radiated. You don't want to radiate them again to something we don't know where it is. So the first patient's easy. The second patient is a problem.
Right, thank you.
You do have a CT component with the PET, and so sometimes you're getting it with contrast. It's like if you had done a more conventional imaging.
Yeah.
And again, at those lower PSAs where you're talking about the likelihood of seeing something in the bone is low to begin with, but I often do convert to sort of something like more anatomic imaging to sort of.
Very good. Thank you.
Thank you to our speakers. Thank you to our audience, and appreciate everyone's participation. Thank you.
That was